Thank you, dear sir, for the kind introduction. So the topic I'll be talking on today will be beyond statins, treating and evaluating residual atherosclerotic cardiovascular disease risk. It's a very huge topic, and to cover it in 15 minutes is actually a big task, but I'll try my best to cover it. So this topic we'll be dividing into two parts. The first will be how do we treat the residual atherosclerotic cardiovascular disease risk. And the second part will be how do we evaluate the ASCVD risk in these patients. So in the major context will be in the diabetic patients. As we all know, the diabetic population in India, the burden that we face, and the risk of ASCVD is always high in these subset of patients. So what do we have beyond statins? So what are the newer lipid-lowering therapies in diabetes that we all should know of? So first, I would like to say that the abnormal lipids increase the risk of myocardial infarction. It is a age-old data that we have, and from many studies before, and even including the InterHeart study. If there are various risk factors for acute coronary syndrome, myocardial infarction, the major risk factor is the lipids. So reducing the lipids has the greatest impact of all the comparable modifiable risk factors. So lipids play a very major role in causing the ACS, and also reduction in lipids has the benefits in reducing ACS. So the very three principles of LDL cholesterol lowering is the lower the better, the faster the better, and the longer the better. So when we say the lower the better, there's no particular number that we come into conclusions. It's arbitrary, but we say the lower LDL, the better the protection. The faster you do it, it's the better, and the longer duration the LDL in the lowest levels, it's better. So lower, faster, and longer of lowering the LDL cholesterol has very good prognosis in case of ASCVD risk management. So and this is also an age-old data that the statin use and new-onset diabetes. So why the concern about statins started in the recent past, and whenever we explain to the patients when we start on statins, is the risk of new-onset diabetes. So we all know that low to moderate risk always has incidence of diabetes, around 7% incidence is always there, and higher intensity statins. Whenever an ACS patient comes to us, we always start them with a high intensity statin therapy, for example, atorvastatin 80 milligram or 40 milligram. So the incidence of diabetes, the new onset diabetes is definitely, the incidence is always around 7% in the use of statin therapy, and with the low intensity or moderate intensity, the incidence is slightly less. With the higher intensity, the incidence is slightly more. So 62% of new onset diabetes cases were among participants who were already in top quarter of the baseline distribution of glycemia. So this means to say that though the incidence of new onset diabetes when we start statins is around a certain percentage, most of these patients who develop diabetes as a result of statin use, most of them would have been in a higher glycemic state. So that is what the sentence says. All right. So now coming to the lipid management. So what are the new goals and the new tools that we have that plays a very important role? So coming to the guidelines. So coming from the bottom of the screen, I would like to say first, adults without an ASCVD. So the arbitrary number based on the data we have is an LDL cholesterol less than 100 we would like to keep, and a non-HDL cholesterol less than 130 we keep. And adults with atherosclerotic cardiovascular disease, but who are not at very high risk, we like to keep it the LDL at below 70 and non-HDL below 100. And those adults with ASCVD at a very high risk, we like to keep the lowest number of LDL less than 55 and a non-HDL of less than 85. So the lower the number of LDL cholesterol, there is the better prognosis and better ASCVD risk management. So suppose in regular practice, what we usually see is if an adult has an without ASCVD, they do not have any risk, we like to keep the LDL less than 100 or non-HDL cholesterol less than 130. But an adults who already have a risk factors of ASCVD like a previous stroke, TIA or MI, they come under the secondary prevention. So secondary prevention, we always like to keep an LDL cholesterol less than 70. So in general, primary prevention, we like to keep the LDL cholesterol less than 100 with a non-HDL cholesterol less than 130. And secondary prevention, we like to keep the LDL less than 70 and non-HDL cholesterol less than 100. And very high risk, the lower the number, the better it is. So the same thing which has been mentioned in the slide, the primary prevention as well as secondary prevention. Primary prevention, we like to keep LDL less than 70 and secondary prevention, less than 100. And secondary prevention, we like to keep the LDL less than 70. So what are apart from the statins, what else do we have to reduce the LDL cholesterol levels, or what are the other non-statin therapies which helps in reducing the ASCVD risk? So along with, apart from statins, we have ezetimibe, which has been tried, tested, and we have bempedoic acid, and newer ones we have PCSK9 inhibitors, evolocumab, balirocumab, and inclisiran. So these are some of the newer molecules that we are having beyond statins that helps us to reduce the ASCVD risk. So coming to the data, what we have, Improve It is one of the trials which showed that addition of ezetimibe along to the statin significantly reduced the ASCVD risk. So the benefit of adding ezetimibe to statin was enhanced in patients with DM and in high-risk patients without DM. So ezetimibe adding on to the statin when the adequate control of LDL is not there. So addition of ezetimibe to statin definitely helps us in reducing the ACS events or ASCVD risk. And we all know bempedoic acid has also come into picture in nowadays, and it can be used across all glycemic spectrum. So importance is like statins, how the incidence of new onset diabetes is there, or some worsening glycemic changes might be there. The bempedoic acid from the clear outcomes data clearly shows that bempedoic acid did not worsen HbA1c, now did not increase the new onset diabetes. And coming to PCSK9 inhibitors, 4-year trial, which is already data which we already have, and evolocumab also was very safe and effective in reducing the glycemia, and also in reducing the ASCVD. So coming to inclisiran, a lot of data are still pending on inclisiran. A lot of research is already going on. So it provided substantial and sustained LDL cholesterol lowering across all the glycemic strata. So a lot of data is yet to come on inclisiran. So in conclusions, patients with diabetes have a higher rates of major adverse cardiac events than persons without diabetes. So they have a higher risk of ASCVD. So definitely we have to look into this subset of patients for a very good prevention, like it be primary prevention or secondary prevention. For LDL cholesterol, lower is better for cardiovascular outcomes, and the longer duration of therapy is better. The lower, faster, longer is the key in reducing LDL therapy. The statin treated patients continue to have ASCVD events despite LDL cholesterol reduction with statin monotherapy. And that is when the newer therapies of beyond statins has come into play. The role of bempedoic acid, ezetimibe, PCSK9 inhibitors, or inclisiran has come into play. So the non-statin therapies provide the same risk reduction per millimole per liter of LDL cholesterol reduction as statins do, and are recommended by all the societies. Recommendations have come up to use combination therapy if you're not achieving the guideline directed recommended levels of LDL cholesterol. So implementation in clinical practice lags far behind the guidelines, and evidence-based new approaches, including earlier initiation of combination therapy, were warranted to improve the implementation. So this time also they specified clearly that combination therapy would always be beneficial in reducing the LDL cholesterol level to the target levels if monotherapy is not working. So, and adherence remains one of the greatest challenges in preventive cardiology in regards to both lifestyle changes and drug therapy. Newer options are available to address this issue. So I would like to conclude by saying monotherapy with statin therapy for reducing LDL cholesterol is good, but if you're not achieving the target levels, do not hesitate to start the combination therapy, which includes addition of ezetimibe, bempedoic acid, PCSK9 inhibitors. A lot of research is going on inclisiran too. So now coming to the second half of my topic, what are the methodologies that we have, or what are the evaluating methods that we have to assess a patient whether he has an ASCVD risk? How do we assess what is the risk factor that he comes into? So any patients with diabetes, we know they have a high risk of ASCVD. So now what are the tools that we have to assess whether what strategy that you should apply to reduce this risk? So what are the modalities that we have to identify the risks for ASCVD in diabetic patients? So lipoprotein little a. So lipoprotein little a, as we all know, the higher the level, more association with higher ASCVD risk. So a lot of data is available on lipoprotein little a and association with atherosclerotic cardiovascular disease. So a lot of data is also available on reducing lipoprotein little a, also reduces the ASCVD risk. So a lot of investigational drugs are going on now to reduce the lipoprotein A levels. So pelacarsen, olpasiran, and many other molecules are all still in the investigational stage. A lot of data is yet to come out, and a lot of material is still be required to completely say that to initiate the treatment for reducing the lipoprotein little a. So I would like to just say that in patients with established type 2 diabetes, elevated lipoprotein little a contributes to the increased ASCVD risk clinical outcomes, as we know by a lot of data, and reducing the lipoprotein little a levels reduces the ASCVD risk. A lot of investigational data trials are going on. So now coming into the other topics, what are the advanced diagnostic imaging? Is your lipid therapy good enough? So do we have any imaging methodology that we have to reduce to assess the risk assessment for ASCVD? So do we have any imaging modalities that helps us to clearly evaluate the risk assessment for ASCVD? So going by all the guidelines, I'm just brushing through because I would like to comment more on the other things. So overall, all the societies have recommended that there is no strong recommendation from any societal guidelines for screening using any imaging. So we do not have a typical imaging pattern to assess the ASCVD risk in these diabetic subset of patients. But we have other methodologies. So what are the screening for obstructive CAD in diabetes mellitus patients? So how do we screen for an obstructive CVD in a diabetic patient? So two randomized controlled trials that we have. So one of the trials clearly shown that the study was mainly on detection of silent myocardial ischemia in asymptomatic diabetic patients. So if you subject diabetic asymptomatic patients to a CT stress testing, when we do a stress testing, if there any, do we identify the ASCVD risk in them? So there was no difference in the primary endpoint of major cardiac events between the two groups. So stress testing did not have a major difference in the two groups. The other is the CT coronary angiogram. So the effect of screening for coronary artery disease using CT angiography on mortality and cardiac events in high risk patients with diabetes. So if there are patients, diabetic patients who you feel they have a high risk of ASCVD and you subjected them to coronary CT angiogram, what was the imaging showed? So again, when you divide them into two groups who underwent CT angiogram and who did not go CT angiogram, the incidence of the composite endpoint did not change between the two groups. So what did we learn from these two things? How do you screen for obstructive CAD, either by stress testing or by CT angiogram? So fewer patients than expected were found to have obstructive diseases. There was no outcomes benefit from revascularization in the presence of obstructive disease which was symptomatic. So you take a diabetic patient, if he remains asymptomatic and you do stress testing or coronary artery and you found out that there was obstructive and you open the lesions, the revascularization did not prove any benefit if the patient remained asymptomatic. So significant improvements but however, whenever you do for a diabetic patient, if you do a stress testing or if you do a CT coronary angiogram and you find a lesion and you treat it adequately with the statin or a more combination therapy or with identifying the blood pressure and lowering it down. So treating it adequately definitely had significant improvements in the further events. So how do you screen for non-obstructive CAD? So we have again many tools. So the previous talk was screening for obstructive CAD that we do in the form of stress testing, in the form of treadmill test or stress thallium. The other one would be CT angiogram. So this is how do you screen in diabetic subset patients for non-obstructive coronary artery disease. So we have many approaches. We have coronary artery calcium scoring, CT angiography plaque identification, and other inflammatory markers. So identification, the presence of coronary artery calcium in the subset of patients with diabetes. So whenever you subject a diabetic patients to a CT scan to see the coronary artery calcium, based on the coronary artery calcium score, did we have any benefit in identifying these ASCVD risk patients? So higher coronary artery calcium definitely has a worse prognosis in the sense they would go on to develop further stenosis, further ASCVD events. Lower or no coronary artery calcium score had a very good prognosis. So coronary artery calcium score definitely has a role. The higher the score, the worse prognosis. Lower the score, lesser the prognosis. The better the prognosis. So coronary artery calcium score for long-term risk classification in individuals with type 2 DM and metabolic syndrome. So it's a study of coronary artery calcium done in those high-risk patients with diabetes. So that also showed that higher the score, worse the prognosis, and the lower the score, better the prognosis. So screening for non-obstructive CAD while on treatment with statins. So if a patient of a diabetes was on treatment with statins, and if you have to identify the screening, the same methodology we use: coronary artery calcium score, CT angioplaking, and the inflammatory markers. So basically, I would like to conclude that there are many modalities to identify obstructive as well as non-obstructive coronary artery disease. So non-invasive assessment of both subclinical atherosclerosis can help reveal the continuum of ASCVD risk. It can inform personalized strategies for CVD prevention. Current guidelines are evolving in incorporation imaging for atherosclerosis, and particularly coronary artery calcium score in further risk prediction of patients with type 2 DM. Imaging can help assess the need for non-statin treatment, like use of SGLT inhibitors, GLP-1 agonists, PCSK9 inhibitors. Current guidelines do not recommend withholding statins treatment in the presence of zero coronary artery calcium score. So there is evolving data on CT coronary angiogram plaque assessment in asymptomatic patients. So basically, there are various evaluating methods to see the risk assessment for ASCVD. One is lipoprotein little a levels. Second, in imaging, no proper guidelines has come up for imaging for ASCVD assessment. But in case of coronary artery disease assessment in diabetic patients, you have to identify an obstructive pathology. You can do a stress test or a CT angiogram, which is valid. And to identify in diabetes patients the non-obstructive coronary artery disease, you have coronary artery calcium score, CT angiogram plaque, and inflammatory markers. So coronary artery calcium has some role nowadays, in the sense that if a diabetic patient is subjected to coronary artery calcium score, the higher the coronary artery calcium score, we tend to know that he has a worse prognosis. So we can do either subject him to coronary artery angiogram, or we can subject him to a high dose statin therapy or a combination therapy to reduce the ASCVD. And if there is no coronary artery calcium or zero score, then they have a better prognosis. Thank you.
Thank you, Dr. Aniketh, for that excellent overview of covering plenty of aspects.
I'm so sorry. The time given to me was 12 to 15 minutes, so I had to rush.
I know that.